to that before we move to an official recommendation.
I want to bring Max in here in a second, but I think something I wanted to get your perspective on, which is really changing in this administration, is, our government is full of these kind of, appointed positions or advisory positions or people that, exist outside the realm of the political, and, whether it's, appointees at the FTC or members of, FDA advisory committees or something like that. We have these people who, are not politicians necessarily, but whose opinions or judgments carry enormous weight. And I think we're seeing a really different relationship between the political apparatus of the government and some of these appointed but, professionalized roles in a certain way. Can you talk about just when you were CDC director, or if you have a sense of history, kind of how you have thought about that relationship where, you were a political appointee, serving at the behest of the administration.
Correct.
That is a political role inherently,
Right.
And yet you have this very important interaction with a body of, I think, people who had historically been thought of as non-political. But am I thinking about that in the right way? How have you thought about that? If you could put yourself in the shoes of an institutionalist.
Well, yeah, so I recognize that, I was, to your point, working on behalf of the president. And, this was not my first time working in the federal government. I had been at the Centers for Medicare and Medicaid Services before, and they make, for example, coverage decisions each and every day. CMS decides, should I cover this? Should I not cover that? And as a political appointee during that time as well, it was very clear that we had a process that was separate from the political appointees. We were very, very firewalled from that process so that the experts could do their work, the career officials, the process could work. It's very similar here. And that is what gave, I think, folks confidence in that process. Is it was folks who were volunteering their time to this ACIP, right? No one was getting paid to do this. They were vetted for their expertise. A lot of them were academics, had long tenures of expertise in this space. They had to fully disclose things. And again, they even did a review of disclosures earlier this year and showed that folks were disclosing the things and posted on the website. And right, and they could give comfort to folks to say, look, there is an independent body here. That's not the person who is working on behalf of the president, who ultimately does need to make the decision by statute. And if there's a differentiation between them, that political appointee should really help us understand why. Because there might be times where maybe the committee didn't see all the chess pieces on the board. Maybe there was something they didn't consider. And the CDC director thought about that. Okay, but then that's in the court of public opinion, and the CDC director needs to explain why. But that is why, look, when I was CDC director and those recommendations came from that advisory committee, I was very quick to accept them because of the rigor of the process, because of the independence of that process. And casting doubt in this moment on what that is very dangerous. And so that is really my concern here, is because that was a process set up to create trust, to make sure that folks knew that it wasn't being, just a political appointee like myself. And it was in concert with these independent experts.
Dr. Cohen, I want to sort of hammer down on maybe some of these critiques of ACIP that seem to be core to RFK's argument here, and we can start with sort of the conflict of interest element. I've interviewed former ACIP members in the past. There was one who mentioned that when he was a member of the committee, he didn't consider a vaccine that I believe his wife worked on at the time. And I think there might be other stories like this where people err on the side of caution. Can you just sort of walk us through that process? Are conflicts of interest disclosed before each meeting? Is there CDC counsel that reviews those conflicts of interest statements? What are the firewalls there? Because I think there's some element where people who support Kennedy's decision here feel that it is, in essence, pals of the ACIP or themselves to just self-disclose, and that doesn't work.
Right. So one, first, folks are vetted on the front end before they are asked to be on the committee. But again, we want folks who have expertise, right? So we want folks who have expertise in the field, but do not have a financial conflict of interest. And so that vetting happens on the front end. It happens at every meeting where folks are disclosing that. And earlier this year, I know that they wanted to go even further and review conflicts of interest and put that on the website for everyone to see and do a review, and they did, and there were no conflicts there that had arisen. This and the fact that we got rid of everyone across the board. Are we saying that every single one? There's no way that they could be independent. Again, these are folks who are volunteers, they're not getting paid to do this work. And so, there are, ethics lawyers who are very involved. And I have heard ACIP committee members saying that this is the most strict disclosures that they have had in their professional lives. So I think it is just not accurate to say that there was not a strong conflicts of interest process or disclosure for participating in the committee.
The other thing that I found interesting in Kennedy's editorial was he brings in the role of the working groups, which I hadn't even heard much criticism of before that. And I guess he takes issue with the fact that the working group meetings are not public themselves. Maybe just give us a little bit of insight into what is discussed at the working groups. I recognize that the working groups are then essentially regurgitating their findings and the data that they looked at to the entire ACIP to discuss, but this seems to feed into the argument that decisions are rubber stamped, that the working group has some predetermined decision. They're going to look at the data, but they're going to sort of ultimately accept these new vaccine products. They're going to then tell ACIP to accept these new vaccine products, and ACIP tends to do that. What is the scrutiny that happens at the working group level that then informs what ACIP is discussing at the whole meeting?
Yeah, well, I want to start with what is the role of ACIP. Again, it is not to decide whether or not these products should be on the market at all. That is the job of FDA, right? So by the time it gets to these work groups and to the ACIP, they're deciding about coverage policy. They're deciding which should be free for kids through vaccine, right? And what should be covered without copay, and what should be the recommendation to which population. So I just want to make sure we understand what they're even asked to weigh in on. Okay, so then you have work groups. And again, this is the ability, you want people with deep expertise to bring data and knowledge to these work, because there's a lot here and it's extensive. And so the work groups are able to get through some of that data and they bring it to the committee. But I have seen in my tenure where a work group brought something to the full committee and they said, we need more information. We're not ready to take action on what that work group brought. Please go back and bring us back more information on X, Y, and Z thing. The work group would bring that. But of course, the ACIP has 2 full days of public, again, very, very public meetings when they go through all of that data, that it is done in collaboration with the career CDC officials to make sure that all of the information from the work group is able to be articulated to the full ACIP group before a vote is taken. They spend hours and hours and hours pre-working on this and then going to a very, very public meeting to look at information.
Dr. Cohen, when you have kind of this resume that sits at this really interesting inflection point, because you were on the ground in North Carolina during the pandemic, and then you moved over to CDC kind of at the tail end of things, and I think at a time when we were really starting to see some of the politicization of the pandemic and things like that, could you feel that inflection point at the moment when you were making that transition? I mean, when you look back now on your time in state government and then your time and after that in federal government, is what we're seeing now, does it feel like, oh yeah, this is exactly the track that I thought we were going down based on what you were seeing on the ground or in your role at CDC? Or does this feel really new and different? Are we in a different world here than you thought we'd be in?
Well, look, I think one of the reasons that I was asked to be the CDC director is because of our success in North Carolina and navigating the pandemic. We, Drew, as you know, we're purple state here in North Carolina. We and I think represent a lot of what the country experienced. But the way we, I think, handled it was in a way to be incredibly transparent, to communicate effectively, to say, this is what I know and what I don't know. Here's how we're navigating through this. This is hard. We're going to come back every day and answer your questions. And we're going to react to new information that we get. And that means, yeah, we're going to get our kids back into school in September of 2020. But it does mean in order to do that, we needed to made some other hard choices. So I'm really proud of what we did in North Carolina. And I think that was one of the reasons I was asked, because I think CDC did need to embed lessons learned from the pandemic. There was early missteps in communication, early missteps around the laboratory test, and how do we make sure that never happens? So I was bringing both and front, thinking about the executive role of changing the CDC and the decision-making process and how to make it more efficient and more effective going forward, and as well as restoring trust from a communications perspective. And I really felt like we were on a really good trajectory. Congress invested additional dollars in CDC while I was there, which I was really grateful to see. It allowed us to prepare. But what we're seeing now, I think, is very different than what I was experiencing at CDC. I felt like, yes, we had some lessons to learn. Yes, obviously the pandemic was hard on so many levels. We've learned some important lessons from that. But this is, I think, a pattern that we have seen from Secretary Kennedy's leadership on or ideology on these issues, unfortunately. And we're seeing that play out in a number of spaces on the vaccine issue. And this is just one more piece to sow doubt, to sow confusion in a space where I think we were rebuilding trust. And I'm worried we're taking steps backwards.
One thing Max and I noticed when we were looking at this announcement yesterday was, I think Secretary Kennedy talked about how if they didn't do this, they wouldn't get, the opportunity to pick their appointees to ACIP. And I think, like, I definitely read that through kind of a political lens very much. But I'm wondering, when you were thinking about, like, when you guys had an opening on the panel or something like that, what were kind of the criteria? I mean, were you looking for, were you looking for people who felt aligned intellectually? Like, what levels of kind of either alignment or criteria were you all thinking about if you did have an opening? Like, I guess, like, how political, let's just to be realistically, like,
Okay.
so
No,
much
great
of life has
question.
been politicized.
Yeah.
Were
Great
you
question.
thinking
Well,
about that at all? Yeah.
first, I think level set. Folks serve 4-year terms at ACIP in a staggered way, right? So by the time you get to the end of the Biden administration, everyone's 4 years has come up, right? So when Secretary Kennedy says they're all appointed the Biden administration, well, that's a feature, not a bug, right? That was how it worked. But there were folks who were appointed during the Trump administration that stayed on ACIP. Now, the other thing I will just say as CDC Director, I was not part of the vetting process. So it's not like I brought a particular perspective. Like, my direction to the team who was working on this was, we need experts. We're going to evaluate data and give us good recommendations. Like, that was as deep as I got into the process, and I think that's how it should be, right? They ultimately do go through a vetting process and go to the Secretary of HHS. But personally, I will just share, I was not heavily involved because I felt like their credentials should stand for themselves in terms of experience in the space and ability to give us thoughtful advice.
I want to also go to your years at CMS before you even arrived at North Carolina, because we were talking briefly before this just about, and you mentioned it at the top of this call, about how if you were to think about ACIP recommendations from a practical, even economical standpoint, it dictates sort of the cost of these vaccines and what insurers have to cover, or public plans. There's a chance, just as a hypothetical, that a lot of recommendations, not just some of these select COVID recommendations, would move to shared clinical decision making as part of this broader effort to stop the government from essentially telling you what to do, as part of, Kennedy's mandate here. What would be sort of the potential private insurance implications of this if that was put in place across the board for a number of vaccines, be it flu, meningococcal, COVID? What would be the impact for many Americans?
Yeah, this is a great question because I would say, I said this as CDC director, I always wanted patients to talk about their vaccines with their doctors anyway, right? So like, that's baseline for all that, talk to your doctor. But what happens with the recommendations, because we're trying to turn policy into operations, when you say in policy, I want shared decision-making, it has some very particular operational implications that we all just lived through with the new RSV vaccine. So when we had the new RSV vaccine, we put it out, it was for older adults, and there was a population where we said shared decision-making. This is new, you should go to shared decision-making, which sounds like a good thing because you're like, you should talk to your doctor, which is what I say about all your vaccine, talk to your doctor. But what happened operationally is that it made it really confusing at the state level to understand who was ordering, who could actually administer the vaccines, what shared decision-making, could that happen with a pharmacist or does it have to be with a physician? As we know, many people get their vaccines at a CVS, at a Walgreens, at the local pharmacy. Can it be a pharmacist in that situation, or what are the legal implications? Does it need a doctor's order? And so you can imagine if a doctor doesn't stock the RSV vaccine, but they want you to get it, that means they have to have this, you as an individual have to both go to your doctor and then go to the pharmacy to get it. And you might need a doctor's order. We ended up taking away the shared decision-making part of the RSV vaccine because it was so confusing for folks. We just needed to be clear. And I will say many of my doctor colleagues are like, look, you guys look at the data all the time. You're so close to it. Just tell us, should we give it to this population? Should it be covered or not, right? We want that kind of certainty on, is this going to be covered or not? And we just add a bunch of operational hurdles. And again, it's not that I don't want folks to talk to their doctor. I absolutely do. And I think they should all the time. This is about the operational pieces that come when you say shared decision-making and the barriers that then, and complexity that happens differently in different states, in different places. So it really makes it hard to say one message about how to get a vaccine.
One follow-up to that, though, because I do think that this was something that I had heard about RSV specifically, because so many people in the RSV population were 65 and older, it likely meant that insurance coverage was actually probably more blanketed because they may have been under Medicare. Is there a chance that if shared clinical decision-making is applied to younger people, teens specifically, could insurers consider that something that they wouldn't cover? Like, are there going to be differences in the private market versus the public, for people who are younger and now their vaccine that was recommended is now under shared clinical decision making?
I think but it's still too soon to know. And so I am trying to learn that myself as well, to understand, are we going to see differences in how insurance plans cover this, or are they going to use shared decision-making as a way to say, yep, it's covered? But even if it's covered, like I said, I think a doctor order is still going to be a barrier, things like that. Maybe it's only covered if there's a doctor order. I do think there's going to be some additional complexity here, but to be honest, I don't think we all know how it's going to play out, which isn't good. Sitting here in June, when we know, the booster cycle for COVID runs with flu, right? We need to be answering those questions now so folks can be getting ready operationally. How many doses should manufacturers make? How many doses should doctors order? How should insurance companies think about that from a systems perspective? We were doing all of that months and months in advance. And so we're already actually late in answering some of these questions.
Max, what do we know about when we're going to find out who these next ACIP members are? And then Dr. Cohen, I mean, what are you going to be looking for as these names start getting rolled out? I mean, this feels like a pretty pivotal moment for setting vaccine policy here.
Well, I don't want to sort of parrot this as sort of official reporting. I have heard this morning that there have been some names that have been selected, though they would need to go through the special government employee process. That's still something I need to learn a little bit more about. Others had reported over the last few months that there had already been some work to select sort of this kind of shadow roster in the event that members were replaced. I think what took everyone by surprise was a complete dismantling of the roster as it existed and not select few that Kennedy may have been able to pitch as deeper in the pockets of industry. Theoretically, it would need to be sometime soon in order for the new members to apply for special government employee status and have that granted. And Dr. Cohen, maybe you can check me on that if there's some expedited process, but I would imagine you would need to see some names by the end of this week or early next. I don't know how many they would be able to have to hold quorum on this. I don't, Cohen, maybe this is maybe where you could chime in and fact check me on this.
Yeah, no, I think you're right, Max, in saying like it is a tall order to think about the vetting and onboarding, because there's real onboarding
Right.
that needs to happen before folks can do this, and then they need to actually review the data
Right.
before we get to a meeting and then get to a vote, right? So I don't see how there could be enough time between now and an end of June meeting to do all of those steps of vetting, the onboarding, the review of data, and get to. So either we're pushing out the meeting, or or I don't know. We'll have to all see how it goes. And I think you're right in saying, like, look, if we want to see names to understand who are these folks, what are their is their expertise in, what is their past work have been, and I hope to see folks that are well versed in these issues to do it. And again, reminding folks, what are they looking at? FDA has already done its work to say these vaccines are ready for the market. This is about, should they get covered for free for children? Should they be recommended for no copay for adults? And how should insurance, right? So understanding what that expertise is as well, I think will be important. So we'll have to see how that plays out over the next probably days, right? If they're going to make it to a June meeting.
I want to ask one last question at the buzzer here, Dr. Cohen, and this is a little broader than the topic we've been on, but this is a key agency that has been without a even acting leader for a number of weeks now. Can you just explain either what you've been hearing about morale at the CDC right now and how the lack of even an acting director or a permanent director sort of impacts the agency's ability to properly coordinate surveillance efforts, whether that's in Texas or the Southeast, or issues that might come up with food, just the impact that this might have at the CDC with no top leadership?
Yeah, look, we have very talented experts at CDC, but every team needs a leader. And when you don't have help, one helping folks prioritize and make sure that we are all moving in the same direction, I think that's a challenge for everyone. And and I think that it's either slowing things down. I mean, the last ACIP meeting, for example, I know that there were recommendations that were made by ACIP that have not yet been approved or not approved by CDC or HHS, if that is. So even that small little piece there is something that's sitting, and it's just causing, again, confusion. Is it going to move forward? Should we go back and revisit that issue? Do we need more information right? Even that small thing, and then we multiply that by thousands of issues. You need a leader to make sure that you are doing the work to protect health and improve lives, which is CDC's mission, and keep everyone moving in the right direction. So I am concerned that they are without a leader, though I know there are a lot of wonderful experts at CDC who continue to do great work.
Well, Dr. Cohen, thank you for joining us today. We did this on the fly. I think most of our viewers are used to seeing my living room behind me. I'm in a tiny little conference room in Manhattan instead. So I appreciate you being available so quickly in the middle of breaking news. Thank you as well to our reporter, Max Bayer, who's been covering this story from the start. That is all the time we have for today. Later this week, we are going to be back with a very cool conversation about AI in biotech. We're going to be talking with Abi Majan, who many of you know from Twitter as Owl Posting. He is a machine learning scientist and biotech worker who writes a must-read newsletter about interesting companies and interesting technologies. We're going to go deep on how AI model works, what happens when they progress past our ability to really understand how they think, and what it might mean for the human scientists who are using them. I promise it is going to be weird, it is going to be philosophical, and it is going to be fun. Today's recording is going to live on YouTube. If you have feedback about what we're doing, send me a note. I want to hear from you. I would love to hear ideas for future guests. If you are already signed up for the Endpoints News Post-Hoc email newsletter, you will get news notifications when we've got a new broadcast coming up. If you are not signed up, head over to endpoints.news. That is our new URL. And in the top right-hand corner, you can hit your reader profile link and then preferences and click to activate Post-Hoc. You can also follow us here on YouTube using that little button below the screen, or on X, LinkedIn, Blue Sky by searching Endpoints News. Thank you to our producer, Nicole Wetzman, our engineer, Dalen Turk. They both make this whole thing work, and we will see you next time news breaks.